Hi, my name is Amelia Leibensperger, and I'm a certified nuclear medicine technologist as well as a certified CT technologist. I currently work at UPMC Pinnacle. My evidence-based practice presentation on my topic of nuclear medicine versus CTA in the detection and localization of acute lower gastrointestinal bleeding, or LGIB, from this point forward. Acute lower gastrointestinal bleeding is a common medical emergency and requires prompt and accurate diagnosis and treatment to help reduce associated morbidity and mortality. According to Grady of Christiana Care Health Systems Department of Radiology, gastrointestinal bleeding is one of the major causes of death in the United States, with mortality ranging from 10% to 30%. Also, Chung and colleagues report the estimated annual incidence of hospitalization for acute lower gastrointestinal bleeding is 20 to 30 cases per 100,000 patients. As a practicing certified nuclear medicine technologist and holding board certification for CT, the management of acute LGIB patients is something I encounter frequently. This is one of the few studies we can get called in for when we are on call as nuclear medicine technologists. And frequently these patients will undergo both nuclear medicine scintigraphy and CTA for detection and localization of the bleed prior to going to angiography in interventional radiology due to our radiologist preference as well as other factors. This results in increased overall radiation exposure for these patients and an increased lag time between when the bleeding actually starts and when embolization through angiography or surgical resection of the colon may take place, which is kind of an issue in emergent, urgent, and subacute cases. The purpose of this presentation is to identify factors related to this issue and develop evidence-based practice recommendations for the diagnostic imaging management of patients with an acute LGIB. In order to begin the evidence-based practice recommendation evaluation, a research question was first formulated based on a PICO format, and the question was as follows. In patients with acute LGIB, is traditional NM scintigraphy or CTA more diagnostically accurate at detecting and localizing an active bleed when compared to the reference standard of conventional angiography? So this focused research question is aimed at guiding the evidence-based practice recommendations following a thorough literature search and synthesis on the topics of NM scintigraphy for LGIB evaluation, CTA for LGIB evaluation, and a comparison of their benefits and drawbacks as well as positive predictive value when compared with conventional angiography. PICO question broken down. P is for the population, which is focused on patients who present to the hospital with an acute LGIB, verified by a diagnosis of LGIB by the admitting physician. I is for intervention, and that consists of the two main diagnostic imaging modalities used to detect and localize an active LGIB, either through nuclear medicine tagged red blood cell scanning or computed tomography angiography, or CTA. C is for comparison, and that then is between the results of NM and CTA studies for this patient population against the results from conventional angiography. As Away and colleagues elaborate, digital subtraction arteriography allows both diagnosis and treatment of gastrointestinal bleeding and is considered the reference standard for LGIB. Finally, O is for outcome, which is what is hoped to be accomplished through this evaluation. Specifically, an evidence-based practice recommendation can be developed and implemented to help increase the diagnostic accuracy of detecting and localizing acute LGIBs to improve patient outcomes through more timely diagnosis and treatment, as well as decreased overall radiation exposure and contrast administration. Listed on the screen for your reference is the formal PICO question. Moving forward to the literature search, a basic overview included a cursory Google Scholar search, which was done on the topic using certain keywords to determine the feasibility of the project and topic. Approximately 479 results populated after using keywords of CTA, nuclear medicine red blood cell scintigraphy, and GI bleeds. Approximately 479 results populated using those keywords, but even this was a lot to kind of muddle through, so additional searches were conducted using more specific databases and more specific key terms to narrow the search. Next, a search using PA College's library databases was conducted, specifically centered on EBSCOhost and CINAHL Complete to help narrow down better key terms to search with after trying the same keywords used in the Google Scholar search and receiving no results. EBSCOhost keywords then included gastrointestinal hemorrhage, computed tomography angiography, and radionuclide imaging to kind of meet up with the previous used keywords, a little more specific for the database searching. And again, GI bleeds was better replaced with gastrointestinal hemorrhage. CTA was not found, so rather the acronym was spelled out as computed tomography angiography instead. And nuclear medicine red blood cell scintigraphy did not populate, so red blood cell scintigraphy only was used and then was better replaced with radionuclide imaging. These three terms were then used to search the EBSCOhost together on related literature, yielding a total of 41 results this time, which was a much more manageable amount as compared to the initial Google Scholar search. A more refined literature search overview then is discussed as followed. The literature search on EBSCOhost was then further refined by adding limiters of publication dates no later than 2013, which is staying within the less than 5 years old guideline, as well as full text articles, because abstracts would do no good for this evaluation. After applying these limiters, only 3 articles were left and only 1 was useful for this evaluation and was then included in the literature synthesis. Additional keywords then were used to refine the search further, as well as look for more relevant articles on the topic. Additional keywords included gastrointestinal bleeding, red blood cell scintigraphy, catheter angiography, MDCT, which is multi-detector computed tomography, and computed tomography itself. And these search terms and keywords were then used with the application of the listed limiters through EBSCOhost and Google Scholar, as EBSCOhost and PA College's library databases are rather limited in terms of allied health research, specifically regarding diagnostic imaging like nuclear medicine, so a broader database search of Google Scholar proved beneficial to this evaluation. On the initial Google Scholar search, 2 articles were identified as applicable to the project based on topic, abstract analysis, publication in a peer-reviewed journal, and were 5 years old or less. 2 articles were received through interlibrary loan, as from the abstracts on EBSCOhost, these articles appeared to be beneficial to the evaluation. These were found using a combination of the aforementioned keywords, and after more specific searches presented limited findings as previously discussed. Finally, another Google Scholar search was conducted using the keywords mentioned on the slide, as well as gastrointestinal bleeding, red blood cell scintigraphy, and catheter angiography. This search yielded similar articles as found on the prior Google Scholar and EBSCOhost searches, along with 1 last article to be used for the evaluation. There was a final total of 5 applicable scholarly peer-reviewed articles after numerous searches of various databases and further refinement of search methods. Overall, it was a rather difficult and frustrating process to find research on this topic, as not much has been conducted in recent years, and the studies have been so specific to other comparisons or imaging modalities, or are literature synthesis or literature reviews, that they won't provide sufficient evidence for an evidence-based practice evaluation. By nature, this topic does not lend itself to a quantitative experimental design due to logistical and ethical concerns. So the majority of research was collected in a retrospective fashion, which overall limits its generalizability to the overall population of patients who experience acute lower GI bleed and are then hospitalized for it. Diving into the literature synthesis, which was a rather extensive portion of the evaluation. Out of the 5 articles reviewed as supporting evidence for this evaluation, all except 1 article compared the use of nuclear medicine scintigraphy to CTA for the diagnosis and localization of acute lower GI bleed. The exception discussed a newly developed processing technique to measure the intensity of an acute LGIB on nuclear medicine scintigraphy and its predictive value for determining the benefit of catheter angiography for those patients. Here are a few examples of the region of interest measurements that the study formulated and applied to positive acute lower GI bleed patient studies. The next closest outlier was Chung's study, which determined the impact of time to positive, or TTP, and lag time, LT, measurements in positive nuclear medicine scintigraphy studies on the probability of a positive catheter angiography study. The base commonality between all 5 studies was the constant correlation of diagnostic imaging findings against catheter angiography findings performed on the same patient, making catheter angiography the gold reference standard in this evaluation, and has been already proven to be the radiology reference standard for acute lower GI bleed patients. All of the studies were of quantitative designs and all collected samples in a retrospective case study analysis fashion, making the samples those of convenience or non-probability samples that were for the most part quasi-experimental, as there were no randomization in the selection of participants. This retrospective fashion of secondary data collection from patient EMRs, electronic medical records, and imaging results limits the overall generalizability of the data, but does not present any ethical concerns to the research methods, as no participant consent was needed for a retrospective chart review. The patient wasn't actively involved in the study, so you don't really need to ask for informed consent. You're just looking at database searching for your PACS system, which is your digital picture image storage system for radiology, or your electronic medical record charts for findings of the studies of interest for those patients. However, for these types of studies, it is almost impossible to design an experiment because instigating an acute lower GI bleed in a patient is frankly looked down upon. It's logistically challenging and overall ethically wrong. So the next best design is a quasi-experimental before and after or time series design, as Davies and Logan would support. Sample sizes were also limited across the board in all studies, ranging from 76 participants in a WAYS study to 194 participants in FARHAT study. This is to be expected again due to the retrospective nature of sampling method, and all studies were limited to data collection at one location except for Chung's study, which included data from 2 tertiary academic university hospitals. Specifically, data collection consisted of measurements defined by the researchers and stated by the interpreting radiologist during case review, either specific to nuclear medicine, interventional radiology, or general radiology. This type of analysis was true for Away, Feuerstein, and Chung studies. FARHAT utilized initial radiology interpretations to narrow their application of the novel processing technique of intensity region of interest measurements in nuclear medicine scintigraphy studies, while Jacobide was not specific as to how radiology interpretations were made, but it is assumed that since there was no specifically stated retrospective review by radiologists, that the researchers used the initial radiology reports for their sample. This threatens the internal validity of the experiment, as inter-rater reliability cannot be measured to compare the interpretations made by different radiologists, as supported by Davies and Logan. Finally, relatively small sample sizes also limited the generalizability of the results, but given the lack of current literature on the topic identified by all 5 sources, the need for further research in a larger setting was agreed upon unanimously. Prior to discussing the literature synthesis findings, a background education on the 3 main diagnostic modalities being discussed is necessary to understand the following results discussion. Background education includes a little more in-depth discussion on nuclear medicine scintigraphy, also known as technetium-99m labeled red blood cell scanning, or nuclear medicine GI bleed scanning. Computed tomography angiography, or CTA, using a MDCT scanner, and catheter or conventional angiography, which is also known as digital subtraction angiography or digital angiography. Nuclear medicine scintigraphy is better known as technetium-99m labeled red blood cell scanning, or a NMGI bleed scan, utilizes a small amount of a radioactive tracer, which is the technetium-99m, and that is then tagged in vitro by withdrawing about 3 cc's of blood from the patient and injecting that into a cold kit containing stannous pyrophosphate. This method has the highest labeling efficiency according to Grady. Technetium-99m is then added to the kit after the red blood cells have kind of been washed almost with a prep liquid to make them more ready to be attached to the radioactive isotope when it's injected into the cold kit. The tracer then, the technetium-99m, is then added, and the tagging takes place over about 10 to 20 minutes. Little variability there depending on if the site has a rocker that they can put the vial on, or if it needs to be hand kind of swirled over that 20-minute time period to make the tagging happen. The now radioactively tagged red blood cells are then drawn out of the kit and re-injected through an IV into the patient, and the imaging proceeds to take place over at least an hour. Imaging acquisition starts as soon as the tracer is injected to capture the initial blood flow down from the abdominal aorta, considering we're looking for a lower GI bleed. Images are obtained by use of a gamma camera, which acquires the counts over a minute per frame and then compiles all 60 frames at the end to create a dynamic image, which is similar to stop frame animation. As stated in Grady, per the CNMT guidelines for gastrointestinal bleeding scintigraphy, the goal of the examination is to determine whether the patient is actively bleeding, to localize the bleeding bowel segment, and to estimate the rate of blood loss. Essentially, nuclear medicine focuses on how the bleed is functioning to capture images to help diagnose the presence, location, and severity of the bleed. Concerns with nuclear medicine through this method of imaging include logistical delays due to lead time needed for radiotracer delivery to the facility, as well as the arrival of the on-call technologist during off hours. The isotopes are not produced in-house. Most often they're shipped in via FedEx to a radiopharmacy that's relatively close to the hospital, and then the pharmacy has to draw up the dose and deliver the isotope via a specialized driver to the hospital before then the technologist can actually use the isotope for whatever imaging they need to do. Being on call, also, by the time you get that phone call, could be 5 minutes after an order's put in, or it could be an hour after an order's put in, depending on how that hospital system works. All these factors kind of pile up to contribute to the lead time that takes place prior to the study being done. Other concerns with this method of imaging also include the time for blood tagging and the lengthy imaging acquisition. Minimum study from the time the patient rolls into the department to when the hour of imaging is complete, 90 minutes if it works quickly. If your patient's difficult, they have poor venous access, they don't want to hold still for the pictures, the radiologist wants more pictures, all of these can contribute to how long that test is actually going to take. And then patients also have to be stable enough to undergo at least an hour of imaging while actively bleeding in the ideal situation. This test does not really work for patients that haven't bled in a few days. And intermittent bleeding may sometimes be identified, but the best scenario for a GI bleed scan is when that patient is actively bleeding. And in that situation, more often than not, you can actually smell those patients are going to be positive before you can see it. The following is a short clip which kind of gives an overview at a nuclear medicine GI bleed scan. And then to summarize the nuclear medicine GI bleed scan, again, you have to have availability of the radioactive isotope, the on-call technologist. You have to have a radiologist that'll be there to interpret the images. Your patient also has to be stable enough to undergo the imaging for at least an hour, as well as having good venous access to draw the blood and re-inject the blood for the imaging. More often than not, these patients have a whole team of people. They're coming from the ICU for this study. Frequently, we've had patients code in our department in the middle of the test, but the radiologist says, well, just keep them stable long enough to finish the pictures. So it's definitely a challenging situation on the technologists, the nurses, and doctors caring for the patient, as well as the patient themselves. Moving forward, computed tomography angiography, or CTA, is performed frequently with MDCT due to its high spatial and temporal resolution. This technology utilizes a type of 3D X-ray exposure to capture highly detailed images of a patient's anatomy. Essentially, you have your X-ray tube in the donut machine, as the patients like to refer to it as, and the X-ray tube rotates very rapidly around that patient as the table slowly moves out of the tube, which then acquires a helical 360-degree view of that patient's anatomy. Iodinated contrast material, or IVP dye, may be injected at various points during image acquisition to help highlight the patient's vasculature and identify areas of extravasated contrast material, which would indicate the presence of a LGIB in this setting. Protocols for image acquisition can vary widely between hospitals, but a protocol comprising of 3 phases of acquisition, including a non-contrast enhanced or scalp view, arterial, which is images captured on a trigger that's released with the CT acquisition. As soon as a certain amount of dye enters the patient's aorta, generally, the image acquisition is then triggered, and an image then is acquired of the arterial phase of blood flow with that contrast for that patient. And then they also have a portal phase, which is kind of a blood pooling delayed phase after that arterial phase has been completed. Generally a minute to 2 minutes after, another image will be acquired to see the venous kind of blood pooling phase. And that type of 3 phased acquisition is the most common adopted protocol for a GI bleed scan. Active bleeding in a CTA exam is characterized by intravenous contrast medium extravasation in the bowel lumen. Again, a patient needs to be actively bleeding for the best results during the CTA to most effectively diagnose the bleed site, very similar to the nuclear medicine scan. Concerns with CTA include the proper prep of the patient. If they're allergic to the IVP dye, they either need to have some kind of Benadryl or antihistamine on board to help with their allergic reaction to the dye, potentially steroids. However, that prep can take upwards of 13 hours depending on the site's protocol. So again, that might not be the most feasible decision to undergo a CTA for that patient at that time if they are actively bleeding. Other concerns, again, allergies to the iodine contrast material. If the patient has renal insufficiency, chronic kidney disease, transplanted kidney, their kidneys aren't going to be able to process out that contrast material well enough, and that can actually lead to contrast-induced nephrotoxicity, which would then kind of involve a shutting down or an acute kidney injury for that patient, which could then cause even more problems. Other concerns also include a higher overall radiation exposure, and again, as mentioned, contrast-induced nephropathy. However, the benefit of CTA is that it's readily available, it's quick to obtain, average of 3 to 5 minutes overall for acquisition, on a comparison of an hour and a half for a nuclear medicine study. And CTA is minimally invasive. The following is a clip of a typical CTA procedure for lower GI bleed.
Here's something even better. This patient was actively bleeding, their crit was dropping pretty precipitously, and you can see that there's an active extravasation in the left colon that's getting bigger between the arterial and the venous phase scans. And here's yet another example. Again, notice how the bleed is getting bigger between the arterial and the venous phase. Now, remember what I said. You don't necessarily have to see the active bleed for this to be a useful scan. If I see lots of ticks, but the patient has a negative CT scan otherwise, this is certainly something you want to bring to the attention of the ER physician.
Finally, catheter angiography, which is also known as conventional angiography or digital angiography, is the reference standard in this evaluation given its widespread use as a comparison standard across the literature. The procedure is performed using a small catheter, X-ray or fluoroscopy, and a contrast material to view the blood vessels of the body. The catheter is normally inserted through the femoral arteries in cases of lower GI bleed. Extravasation of contrast material helps to identify the source of the bleed and may even be embolized during the procedure to stop the bleeding as compared to having surgery. Catheter angiography allows for both the diagnosis and treatment of acute lower GI bleed. However, this method is a rather invasive technique with an increased risk of procedural related complications. It can be very time consuming. It increases the patient's radiation and contrast exposure proportionally to the overall time length of the procedure and requires an experienced interventional radiologist to perform the procedure. The following is a brief overview of catheter angiography. After that background review, we can move forward to the literature synthesis and discussion of findings during the literature synthesis. Acute lower gastrointestinal bleeding is a serious medical condition that leads to almost 1 million hospitalizations annually in the United States and is a major cause of morbidity and mortality. Accurate, efficient, and timely assessment, identification, and localization of acute lower GI bleed are of the utmost importance in successfully managing and treating this condition. There are a variety of diagnostic imaging modalities available to detect and localize the source of lower GI bleed in a patient. Colonoscopy is one of the most popular options as it can directly visualize the cause of the bleeding and can be used therapeutically in the same setting. But it's technically difficult in patients who are actively hemorrhaging, is time-consuming, and requires the patient to be prepped appropriately, and is about roughly 50% accurate in its sensitivity for localization and identification of lower GI bleed. Catheter or interventional angiography is known as the gold standard when dealing with a lower GI bleed, as it can be both used to diagnose and treat a gastrointestinal bleed. However, this is often seen as an invasive procedure with associated risks of radiation exposure, side effects to contrast administration, sedation requirements, and post-procedural complications, as well as added financial burden to the patient. It is not a cheap procedure to have done. In current practice, both technetium-99m labeled red blood cell scintigraphy and computed tomography angiography, or CTA, are used interchangeably in an attempt to detect and localize an acute lower GI bleed. Technetium-99m labeled red blood cell scintigraphy has long been the first-line standard in diagnostic imaging to non-invasively detect the source of a lower GI bleed, as this nuclear medicine procedure is highly sensitive for detecting gastrointestinal bleeding, up to 93% sensitivity in a bleed as slow as 0.04 milliliters per minute, and provides the option of prolonged imaging that is well suited for intermittent bleeding, according to Farhat's study. However, nuclear medicine red blood cell scintigraphy is not nearly as specific in localizing the source of the bleed, according to a study performed by Feuerstein. In this study, a comparison between the efficacy of CTA and traditional red blood cell scintigraphy was conducted for the accurate localization of acute lower GI bleed. They found that CTA was more accurate in localizing the site of the bleed, but the two modalities were comparative in the identification of active lower GI bleeding. On the other hand, CTA is highly specific in the localization of lower GI bleed due to the anatomic detail and quality of imaging performed as compared to nuclear medicine red blood cell scintigraphy. In a recent study conducted by Away, patients who underwent both CTA and red blood cell scintigraphy imaging for acute lower GI bleed were compared to determine which diagnostic modality was more accurate in the detection and localization of acute lower GI bleed when compared with a reference study of conventional angiography, which was then performed after the CTA or red blood cell scintigraphy study on the same patient. The conclusion was that CT was 96% accurate as compared to 55.4% overall accuracy of red blood cell scintigraphy. Pretty wide variation in diagnostic accuracy between the two. Away and Feuerstein both found that there is a gap in current literature regarding a direct comparison of patients who underwent both red blood cell scintigraphy and CTA prior to conventional angiography to determine the efficacy comparison of the two diagnostic imaging modalities. New processing techniques, like the one explained in Farhat's study, could bridge the gap in determining how necessary catheter angiography is following red blood cell scintigraphy, depending on the quantified intensity of the lower GI bleed from that study. Additional measurement of time to positive by the interpreting radiologist during initial interpretation of the study will further help to determine which patients would benefit from catheter angiography for treatment. This will also increase the likelihood of positive findings on catheter angiography, which will act as a positive feedback mechanism to decrease lag time between red blood cell scintigraphy and catheter angiography. Previous implementation of a treatment algorithm recommending the use of CTA for the evaluation of patients with acute lower GI bleed also proved that using CTA prior to catheter angiography was statistically significant in that it more than doubled the identification of the hemorrhage site due to catheter angiography. Previous implementation of a treatment algorithm recommending the use of CTA for the evaluation of patients with an acute lower GI bleed also proved that using CTA prior to catheter angiography was statistically significant in that it more than doubled the identification of the hemorrhage site during catheter angiography. Thus, current practice involves a mix of nuclear medicine red blood cell scintigraphy, CTA, and catheter angiography to diagnose and potentially treat an acute lower GI bleed, with patients frequently going for at least 2 of the aforementioned procedures. The cumulative radiation dose received is a risk that needs to be addressed in a more efficient manner than is currently occurring to better patient outcomes overall. After the literature synthesis was conducted, a practice recommendation was formulated in this evaluation. The practice recommendation is as follows. CTA should be utilized as a first-line diagnostic tool for patients with active acute lower GI bleed that are stable enough to undergo imaging and are not contraindicated on the basis of allergies or renal insufficiency. CTA has been shown to be as sensitive as nuclear medicine scintigraphy in the detection of an acute lower GI bleed, but has proven superior to nuclear medicine scintigraphy in the localization of an acute lower GI bleed, as supported by Jakovid, Feuerstein, and Away. This important difference is not only advantageous for patients needing therapeutic intervention for bleeding cessation, as it will override the need for multiple imaging studies prior to catheter angiography and/or surgery, but it will also reduce the overall radiation exposure these patients receive in the course of diagnosing an acute lower GI bleed, as well as the detection of that bleed. For intermittently bleeding patients and those contraindicated for CTA, nuclear medicine scintigraphy should be utilized, and processing should include intensity region of interest measurements to aid the radiologist in interpretation of positive studies. The radiologist should also make note of time to positive measurements for the study to help decrease lag time between positive findings on nuclear medicine scintigraphy and performance of catheter angiography or surgery, as well as identification of which patients will most benefit from catheter angiography, as supported from findings in Farhat and Chung studies, respectively. These small changes can be added into the technologist and radiologist normal procedures for processing and interpreting these studies, and with some instruction and education should be a relatively minor change to current practice. These techniques will also help to decrease the subjectivity in the interpretation of these nuclear medicine scans, as well as increase the confidence of the interpreting radiologist's recommendation for angiographic evaluation and treatment, when paired with a time to positive threshold of less than or equal to 9 minutes, as in from the time the scan starts to when bleeding is identified. That is a 9-minute or less timeline. If the bleeding doesn't show up on the scanning in that 9-minute time frame, it's generally not as emergent for that patient. Could be intermittent, and it could also have self-limited itself. Depending on the results of these diagnostic imaging tests, catheter angiography should then be performed with the goal of embolizing the site of lower GI bleed during the procedure. Confidence of the correct recommendation for either further evaluation or treatment with catheter angiography is increased with the ability to accurately pinpoint the location of lower GI bleed with CTA and MIP reconstruction capabilities, as well as utilizing new processing and interpretation techniques to determine how likely catheter angiography will produce positive identification of the lower GI bleed following nuclear medicine scintigraphy. The combination of these methods used altogether will overall help to improve acute lower GI bleed patient outcomes by streamlining the diagnostic imaging and intervention process for these patients. There are several barriers that exist, though, for this practice recommendation to be put into effect, and they must be taken into consideration when a facility is considering adopting this recommendation. These barriers may include the following. Increased costs to the patients, as CTA is commonly more expensive than nuclear medicine scintigraphy, although this is highly dependent upon each facility. In this review alone, there was a price difference ranging from approximately $40 to $960 between the two studies, with CTA consistently being the more expensive out of the two. The patient also has risk of increased contrast and radiation exposure, through increased performance of CTA followed by catheter angiography. Both of these modalities utilize ionizing radiation in the form of X-rays to image the lower GI bleed, as well as IV iodinated contrast agents to identify the location of the bleed. This poses an increased risk to the patients for the development of cancer or contrast-induced nephrotoxicity. Logistical barriers are potentially more applicable at smaller facilities who may not staff round-the-clock CT technologists, nuclear medicine technologists, nuclear medicine-specific radiologists, or interventional radiologists, or those who do not have the imaging equipment available for the adoption of this workflow for lower GI bleed management. Finally, the facilities who want to adopt these practice recommendations may be faced with increased costs to update their processing software for the adoption of the region of interest intensity measurements in nuclear medicine, additional cost for training of additional staff members to adequately staff a facility to perform all of these diagnostic tests, as well as the increased amounts of contrast needed to perform CTA for lower GI bleed. All those costs will factor in to potentially be a barrier to this recommendation. There are several important takeaways that the audience should be aware of during the conclusion of this evaluation. Takeaways include acute lower GI bleed is a common and life-threatening medical emergency. CTA, nuclear medicine scintigraphy, and catheter angiography are diagnostic tools for dealing with patients with acute lower GI bleed. CTA used as a frontline diagnostic tool combined with enhanced nuclear medicine scintigraphy processing and review will aid in the positive predictive value of catheter angiography and decrease the lag time between initial identification of the lower GI bleed site and performance of therapeutic intervention, either through catheter angiography, coil embolization, or surgical resection of that portion of the colon. In conclusion, acute lower GI bleed is a common and life-threatening medical emergency that must be diagnosed and treated in a timely manner to most improve patient outcomes for that situation. Nuclear medicine scintigraphy, CTA, and catheter angiography are commonly used to diagnose an acute lower GI bleed, with the exception of catheter angiography, which may also be used to aid in the cessation of the bleed. Research has been conducted to determine which method of diagnosis of acute lower GI bleed is more diagnostically accurate when compared to the radiologic reference standard of catheter angiography. However, not much research on this topic is available and is limited in its generalizability due to the retrospective nature of data collection in this setting. The following literature synthesis found that CTA and nuclear medicine scintigraphy are similar in their sensitivity for the detection of an acute lower GI bleed, but CTA is overall superior due to its superior ability to localize the lower GI bleed, as well as its ease of performance. It's more readily available than nuclear medicine, and it's faster than the traditional nuclear medicine scintigraphy, which overall makes it more diagnostically accurate. However, intensity, region of interest measurements, and time to positive measurements during nuclear medicine scintigraphy processing and review hold positive predictive value as to the benefit of catheter angiography for the successful localization of the lower GI bleed in those patients. The performance of CTA in all patients with acute lower GI bleed, unless otherwise contraindicated, will help to reduce the number of imaging studies needed overall for the detection and localization of an acute lower GI bleed, as well as to reduce the amount of radiation and contrast exposure utilized in catheter angiography. They know exactly where to look. They don't need to spend as much time using the fluoroscopy and contrast to identify exactly where the bleed's happening. Nuclear medicine scintigraphy is still beneficial in lower GI bleed detection and localization for CTA contraindicated patients, and can further be enhanced with intensity region of interest measurements and time to positive determination, which all will help to expedite the decision to proceed with catheter angiography or not for that patient. Barriers to these practice changes include consideration of increased cost and radiation exposure to the patients, as well as the logistical barriers and increased cost to the facility. However, as a nuclear medicine technologist and certified CT technologist, the benefits of CTA for these acutely bleeding lower GI bleed patients far outweigh the benefit of nuclear medicine scintigraphy for the detection of the bleed. CTA is much faster, those patients are relatively unstable, and the speed and accuracy and localization that CTA provides for the detection of the bleed again, is much more beneficial for that patient's overall outcome as compared to spending minimum of an hour in the nuclear medicine department attempting to find the bleed. So if the patient's not actually actively bleeding, that time in nuclear medicine is essentially a moot point. There's really no purpose. Whereas if the patient begins bleeding, the time it takes them to get to the CT department, perform the CTA, half the time of the nuclear medicine study, which may or may not detect the bleed. And then the information gathered from the CTA with MIP reconstruction is then very beneficial in aiding the interventional radiologist during catheter angiography to help determine exactly the location of the bleed site, go right there, embolize the site, and overall stop the bleeding in that patient, which again will help to improve their overall outcome. Although blood can be transfused for these patients, depending on the speed of the bleed, that person's only going to last so long. This practice recommendation should be considered, just taking into consideration why not do a CTA, compared to a nuclear medicine study first and see what that tells us, and then move forward. And do we still need the nuclear medicine study if the bleed's intermittent, or if it's very positive on the CTA, let's get them straight to IR or the OR to take care of the bleed and help that patient. I'd like to thank you for attending this evidence-based practice presentation on nuclear medicine versus CTA and the detection and localization of acute lower GI bleed. And the following are references for the presentation.